Good afternoon, everyone. We're going to give it one more minute before we get started to let people trickle in. Again, my name is Kyle. For those that don't know me, I'm the coordinator for the Bite-Size Lecture for this year, upcoming year.
Can't hear you.
Thank you for that. Thank you for that. So before I introduce our speakers, I would like to open up with the mission statement for the Southeast chapter, which is to emulate SCCM's mission, which is to secure the highest quality of care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. With that, I would love to thank our speakers today. Today we have Dr. Dave. He is an assistant professor of emergency medicine and anesthesiology at Emory University School of Medicine. He currently serves as the co-medical director of Emory ECMO program. His primary focus is the adult critical care medicine in cardiovascular ICU at Emory University Hospital. We also have Dr. Ryan Rodriguez. He is a critical care NP with over 8 years of experience, currently practicing in the cardiovascular ICU at Emory University as well. We also have Jesse Blakemore. He is an ICU nurse with 6 years of experience. Of those, he has been an ECMO specialist for 5 years and worked at Kettystone Regional Medical Center and currently working at Emory University Hospital. And then finally, we have Dr. Jolie Gallagher. She is a critical care pharmacy specialist in the cardiothoracic surgery ICU at Emory University Hospital. She also serves as the clinical coordinator for the critical care and cardiology pharmacy specialist. Her interests include medication management in ECMO and life support, as well as delirium, sleep, and ICU transition of care, and antimicrobial stewardship. With that, I would love to hand it off to our speakers and look forward to a wonderful presentation. Thank you.
All right, thank you very much, Kyle. Can everyone see my screen okay? Take that as a yes. There we go. All right, everyone. My name is Dr. LeVay. I'll be presenting a talk today titled Saving the World, Extracorporeal Membrane Oxygenation for Respiratory Failure. I have no financial disclosures, but a bit of a disclaimer. I believe ECMO can save the world, and over the next few minutes, I hope by the end of it, you'll believe that too. So what is ECMO? ECMO is extracorporeal membrane oxygenation. So what this means is there's something outside the body that's artificial that provides oxygenation. After the discovery of heparin, ECMO has been around for now close to about 80 years. In 1953, the first successful use of ECMO was used in the operating room during an atrial septal defect repair. The first successful use of ECMO was seen outside the operating room in 1971. Dr. Hill successfully treated a 24-year-old male after a motorcycle collision with ECMO. Dr. Bartlett, considered the father of modern extracorporeal support, treated baby Esperanza for meconium aspiration. The picture here on the right is her at the age of 20. After a majority of ECMO was initially used in children, seizure and Neolia were two landmark trials that not only showed that ECMO potentially has a very pivotal role for adult VV ECMO cases, but also marks an increase in rise in ECMO use as well as ECMO centers. After multiple trials that have helped refine selection, have shown advancement in technology and sophistication in management, there's been significant mortality improvement with the use of ECMO, that we are now in an era of trying to find out what its best home is in medicine. So why to use ECMO kind of comes back to the only business class I took in undergrad, microeconomics, discussing supply and demand. When oxygen delivery cannot keep up with oxygen deficit, you develop cellular injury, particularly when this oxygen deficit is irreversible. You then lead to cellular death, tissue injury, and then multi-system organ failure. Here is what I call the equation of life, or the delivery of oxygen equation. A lot of our treatments in medicine are centered around fixing problems in this equation. Someone has cardiogenic shock, you give them an inotrope. The trauma patient gets a massive transfusion protocol. The patient with pneumonia gets intubated. ECMO does something similar. ECMO takes blood out of the body through a drainage cannula or an outflow cannula, puts it through a pump, which then goes into an oxygenator and a blender. What this system does is instills oxygen, removes carbon dioxide, then blood is returned through a return or inflow cannula. There are two broad types of ECMO. There's VV ECMO and VA ECMO, named particularly on where these cannulas sit in the body. Speaking of, for VV ECMO in particular, in primary respiratory failure, this is seen towards the refractory end of therapies in ARDS and respiratory failure. So patient comes in, you start with supplemental oxygen, progressive non-invasive positive pressure ventilation, mechanical ventilation, and then after that you get into paralytics, proning, and then find yourself having an indication for ECMO. Here in 1971, Zappel and colleagues showed the first published inclusion and exclusion criteria for ECMO. As you can see, the inclusion criteria are primarily centered around hypoxia, with an incredibly broad exclusion criteria. Since then, subsequent trials have described inclusion and exclusion criteria that all have about the same general take-home points. If you're young in age, if you've been on the ventilator for a short period of time, and if you're profoundly hypoxic refractory to therapies, you may benefit from ECMO. And so broadly, the indications for VV ECMO are refractory hypoxemia and refractory hypercapnia. That to be said, no study to date has demonstrated definitive benefit. There are several recommendations, though, that exist for ECMO initiation. When speaking of evidence in ECMO, I do find myself thinking about one of my favorite publications in the British Medical Journal, which discussed that there was a lack of RCTs to show that there's a definitive benefit to wearing a parachute when jumping out of an airplane. Basically to say, sometimes we don't have all the all the evidence to know that an intervention is probably beneficial. Also, guidelines here published this is in 2017, show the inclusion criteria, which centers around hypoxia, but also around refractory hypercapnia. Also describes severe air leak syndrome, or patients that have severe pneumothoraces or barotrauma or bronchopleural fistulas, as well as a use for ECMO in transplant patients. One of the criteria to be listed for lung transplant is being able to ambulate and work with physical therapy. Being freed from a mechanical ventilator and on ECMO support can aid in that. Exclusion criteria is generally long amounts of times on mechanical ventilation, other pre-existing conditions, and then generally an increased risk with increased age. But showing specifically, there's no absolute contraindication. These are all relative contraindications and should be a discussion. So for our institution, we described that the decision to cannulate or not to cannulate should be a multidisciplinary discussion. The burden for withholding ECMO, a potentially life-saving therapy or support, should never fall on just one's shoulders. It's just too powerful and dangerous of a tool. Now, in terms of steps for cannulation, this is similar to placing a central line. You put a needle into the body. That needle is then used to get purchased with a wire. Then using serial dilation, you create a tract in a soft tissue that allows for a catheter or cannula to be placed, also described as Selzinger's technique. Now, different from a central line, the size of these cannulas are much, much larger. You're talking 7 to 10 times the size of a standard central line. And so there is potential risk that can happen with not only vascular injuries, but malplacement or injury to the structures around where you're cannulating or placing the cannula that can occur with these steps in cannulation. So it's important that those who cannulate understand that experience is important to respect these complications and ways to avoid them. And as anyone who's ever done procedures, we're all familiar with the Dunning-Kruger effect, which is when we start doing procedures, things are going great, and we think there's never ever going to be a complication, and then we hit one, confidence drops incredibly, and then as we gain more experience, we gain expertise. Now, there's a misconception that cannulation can only occur in the cath lab or operating room. The advent of bedside ultrasound has allowed bedside cannulation and initiation of ECMO to occur incredibly safely at bedside in any arena inside our center. It's not only in our center, but also outside our center as well. Here's a map of places we've gone over the past 5 years to go cannulate for ECMO. As you can see, some of its majority in Georgia, but also extends out through the Southeast region and as far south as South Florida. And so here's a few pictures of different hospitals where we've gone to for these quote-unquote remote cannulations, where patients were successfully and safely initiated and cannulated for ECMO. After they were placed on ECMO, they get transported back. The picture here in the center shows a patient on a stretcher, along with the ECMO circuit, ventilator, and medications. The machine right sitting on that table, that's the entire ECMO circuit. Once the patient's packaged up, we either drive home or in some instances fly back to our center. After cannulation, management centers around a principle that we learned since the first publication of ARDS. So here I have a picture of that publication in 1967. The first description of ARDS was published at that time in a small journal known as The Lancet. What we know now since that publication is that the ventilator is not benign, but can be the devil. Ventilator-induced lung injury and the damage it can do to a diseased lung can be quite profound. What ECMO allows us to do for management is place the patient on protective ventilator settings while using gas flow to exchange oxygen and carbon dioxide, recognizing this doesn't treat anything, but helps support the patient while treatment is occurring. Setting that expectation for family is important. So having those conversations before cannulation and then afterwards, recognizing palliative withdrawal of care on ECMO can have elegance, as well as the impact of perceived futile care on ECMO and what that can have to not only the patient, but the family and the staff caring for those patients. And so I like to talk about options for not only the patients when I cannulate them, but also afterwards. That, we have basically 3 paths. We have the road to recovery, which we're all hoping to go down. We have the road to lung transplant if we can't recover, recognizing the road to lung transplant has both medical as well as social and economical obstacles to overcome. If those 2 paths we can't go down those 2 paths, then the third road is the road to nowhere. And recognizing that if we've tried the first 2 paths and we're on the third one, we're talking about how to palliatively end care on ECMO. But we've had quite a bit of success, not only for recovery and transplants, to where I can say ECMO can save the world. Maybe not the world like the Avengers and, an invasion on New York City, but the worlds of these individuals and their families, where they were able to come back and not only survive, but thrive in their lives. And now, this was only possible because it takes a team. It cannot be done alone. ECMO takes not only the team taking care of the patient initially, but who recognizes that they can benefit from ECMO, the initial team taking the consult, those who go out to go cannulate, those who transport the patient back, manage the patient at bedside, all the way from the respiratory therapist to the physical therapist to the nurses, providers, doctors, and then as well as the team taking care of them, their post-ECMO care. But this cannot be done alone. It needs this entire team to take care of them efficiently. And so, in summary, here's a few things to know on your next shift. Before those reviews, I have here 2 QR codes to our ECMO app. Here you'll find indications and contraindications, as well as a point of contact when looking for an ECMO consult for a center. What you need to know for the next shift is that VV ECMO is for refractory respiratory failure. It does not treat, but it supports the patient. The decision to cannulate should be a multidisciplinary discussion to set expectations for ECMO support early on and then through their care. If calling for ECMO, call early, as cannulation initiation can be performed safely outside of procedural areas. And then ECMO takes a team, and it can absolutely save the world. Thank you.
Do you guys see the presentation?
See a white screen.
You seeing a presentation or no? Hang on.
Okay.
All right. All right, so my name is Ryan Rodriguez. I'm an NP in the CVICU here at Emory, over at Emory. And today we're going to be discussing predictive scores related to VV ECMO. I have no relevant financial disclosures. Some of the objectives is we're going to review briefly what candidacy is for VV ECMO and respiratory failure, the utility of predictive scores in VV ECMO, what are the current, relevant predictive scores, maybe some past and present ones, and then important implications and limitations to predictive scoring systems. So first, why we need why we might consider predictive scoring measures. There is an increasing use of ECMO, as previously mentioned, first used in the 1970s. There's been an increasing use since 2009 with H1N1, and then after the Caesar and Neola trial that basically supported ECMO as a valid treatment in patients compared to mechanical ventilation. There's also been, following COVID-19 pandemic, there's been an increasing percentage of what would be considered high volume ECMO programs, being greater than 20 cases per year. And that rose from 29 to 41%. So it is being utilized with a higher frequency. There's also early interest in identification of patients who might benefit from ECMO and ECMO center referral. There's also been more establishment of what we call ECMO centers that can manage these high-risk patients because they are very resource intensive. And then although use of it can remain controversial as to timing, candidacy, all those things, there is an importance, as previously mentioned, in a multidisciplinary decision-making process. So some brief indications, just a reminder, it's a supportive therapy. It is not disease modifying, but some of the main ones we might see for VV ECMO are ARDS, pulmonary hemorrhage, severe asthma, airway obstruction, inhalation injuries, thoracic trauma, bridge to transplant, and some of the other things we might consider or causes would be ARDS with refractory hypoxemia or severe hypercapnic respiratory failure in patients typically in the below 65, 70 years of age. Some contraindications, there's no real absolute contraindication, but we want to make sure that we're considering that this is a reversible disease process or that there is an appropriate bridge. Some other potential contraindications, metastatic malignancy, significant CNS injury, multi-organ failure, etc. So support for predictive scoring in ECMO might guide patient selection, might guide clinical decision-making or early initiation of ECMO, may aid in referral to an ECMO center. Keyword being a guide here. They're not to supersede clinical decision making itself, but it aids in reducing the potential subjective or bias associated with ECMO candidacy, and factors in relative indications and contraindications. It also helps risk stratification linked to poor outcomes, such as extrapulmonary factors, multisystem organ failure, renal failure, and then they can also focus broadly on the pathology of respiratory failure, which specific causes of refractory hypoxemic respiratory failure or hypercapnic respiratory failure may have better outcomes and support early candidacy compared to some others. And then lastly, just making sure that we're considering it's a multidisciplinary decision-making process. So some predictive scoring systems here. I've starred the ones that you will probably see or hear of that get utilized probably more regularly. But some of the previous ones are ECMO-Net, the ROKE score, mortality score, Murray score, which was initially developed to evaluate level of acute lung injury, and now can be utilized as a potential for referral. And then you have the RESP, the PRESERVE, and the preset, as you can see there. Although most of these primarily focus on mortality, there are some variances in what the variables related to the scoring systems considered, such as ECMO center referral, extrapulmonary considerations, respiratory diagnosis, even BMI. And the ones, like I said, largely utilized are the RESP, PRESERVE, and preset. And they've undergone quite a bit of external validation and regular application as well. So the ECMO-Net is one of the earlier ones used. It did consider extrapulmonary function prior to ECMO with variables such as MAP, bilirubin, creatinine, hematocrit. This was a cohort of 60 influenza patients during H1N1. And the what's called the area under the receiver operating curve is basically a statistical measurement that summarizes the overall diagnostic accuracy of a test, 1.0 being perfect. But in the cohort of the 60 adult patients, it was 0.85, but on validation on non-influenza patients, about 0.69. So those are relatively accurate. But it was primarily aimed at aiding in resource allocation and timing of ECMO initiation. The ROKE score is aimed at identifying risk factors associated with mortality in ARDS patients treated primarily with mobile ECMO and following referral to an ECMO center. The focus being that they were referred to an ECMO center. And those variables included the SOFA score, or your sequential organ failure assessment score, utilizing lab and clinical data to predict ICU mortality, similar to maybe you've heard of an Apache score, both helpful in determining the level of acuity and mortality potential. Age, presence of influenza, pneumonia. Exclusion for this cohort was age greater than 70, mechanical ventilation greater than 7 days, and a SOFA score greater than 18. And you can see the area under the curve there. The VV ECMO mortality score, this emphasized an importance of extrapulmonary organ function as well, or organ dysfunction. Had 3 binary variable predictors that evaluated is a patient immunocompromised, SOFA score, and days of mechanical ventilation. And the lower score ranged from an 18% mortality to the highest score of 88% mortality. The only patients that were included were those with a P to F ratio of less than 70. And the purpose of this was basically a simple risk evaluation to identify patients with the highest potential for poor outcomes. Some of you may be familiar with the Murray score. It was initially developed in, I believe, 1988 to assess the severity of acute lung injury in ARDS. And then later was used in the CSER trial to determine which patients were appropriate for ECMO referral. Variables of this score included consolidation on chest film, be it by quadrants, P to F ratio, PEEP, and then lung compliance. And then you can see here the scoring greater than 2.5 was considered severe, and on the CSER trial, Murray score greater than 3.0 supported patients that should be considered for ECMO center referral. So now one of the more commonly ones used is the RESP score to predict survival to hospital discharge. This was developed utilizing registry data from ELSO, Extracorporeal Life Support Organization. It does give consideration to the disease process and its reversibility, and I'll kind of discuss that further on the next slide, but 5 risk classes ranged from 8 to 82% mortality, and some variables included age, immunocompromised state, respiratory diagnosis, CNS dysfunction, use of inhaled nitric oxide, neuromuscular blockade. It did not, however, include or consider prone positioning. And then one of the other scores it is commonly interchangeably used with is the PRESERVE score, which both of these, the RESP and the PRESERVE, have gone through quite a bit of external validation. You can see the area under the curve there, 0.65, which was similarly accurate to the PRESERVE. One thing I found was it was difficult at predicting mortality during COVID-19. Patients in lower risk classes actually had worse survival than those in higher risk classes, so it was just an interesting kind of paradoxical effect. So here's kind of the scoring system you have here. And one thing I'll point out is the consideration to what the underlying pathology is. So if you look, you can see asthma has a score of 11, and the aspiration pneumonitis of 5. So this significantly impacts the RESP score in a positive manner, and would support that, these patients tend to have more favorable outcomes. Which is why, some of our status asthmaticus patients may be a appropriate candidate early for ECMO, given that they have potential for such good outcomes. And then you can see here on the top right what those scores are, greater than 6 being a 92% survival, all the way down to less than -6 of 18%. The PRESERVE score, this was associated with death by 6 months post-ICU discharge. It did also factor into some patients who answered in the post phase at 6 months related to quality of life, which I do think is something in the immediacy of the ICU, taking care of these resource-intensive patients that we may not always factor in, persistent physical and emotional difficulties, anxiety, depression, PTSD following. So I found that this was kind of an interesting focus on a quality of life perspective. Variables included age, BMI, SOFA score, mechanical ventilation greater than 6 days, lack of proning, and then the area of the curve ranged from 0.59 to 0.67. With regards to the PRESERVE, one of the more interesting highlights here is that BMI actually was a more favorable prognostic indicator. The scoring itself is inverse to RESP, so the higher the score correlates to a lower chance of survival. So here you can see the 0 to 2 is a 97% compared to the RESP being the higher the better. In terms of BMI, there's been some studies that have looked at why patients with a higher BMI, maybe class 2 or 3 obesity, may not be immediately a non-potential candidate for ECMO. I think initially when you're factoring in cannulation of these patients, pre-ultrasound and bedside fluoro, you had to cut down on these patients. So there was a significant risk of bleeding or difficulties associated with cannulation. But that's obviously gotten improved with the use of ultrasound and fluoro. And then, you know, the other consideration is maybe these patients might need a higher flow requirement given body habitus. So, you know, the potential for additional cannulation strategies, VVV, ECMO per se. Some other things to consider with this score with a BMI is, you know, maybe we're considering early pronation of these patients or esophageal balloons for titration of PEEP. But some studies that looked at BMI as a whole being a contraindication to VV ECMO one of them showed that patients with higher BMI actually in some instances had lower levels of severe pro-inflammatory cytokines, which could be a little bit more protective. And then some other studies showed that there was no association with increased mortality and suggested there might actually be an obesity paradox in patients on VV ECMO as a survival standpoint. The preset was formed during an analysis of 4 prior risk scores, the ECMO-NET, the RESP, the PRESERVE, and the ROKE in 2017. And then they utilized that, the efficacy of those to try and develop a new score, the preset. It did demonstrate a decent accuracy in COVID-19 patients. The pre-ECMO hospital length of stay, MAP, lactate, pH, platelets were all utilized here. And they found that platelet count actually was an important predictor with a decrease of 100,000 being associated with a 30% increase in mortality. So these extrapulmonary factors are important when we're considering our patients. And this is, you know, how the allocation of its scoring is developed. You have to see risk class 1, 2, and 3 mortality of 26, 68, and 93 respectively. So some implications and limitations to ECMO scoring systems. So, you know, we need to consider the extrapulmonary organ function prior to ECMO initiation. You know, early initiation of ECMO is important, shouldn't be delayed. Longer durations have been associated with worse outcomes. Consideration for bias, importance of multidisciplinary decision-making, prognostication, and what the bridge availability is for our patients. Some of these scores may lack practicality as well. You know, some perform better with influenza patients compared to some others. So, you know, the overall application and practicality of them. And then, you know, I imagine we'll continue to see those scores going forward as a useful tool in decision-making in early ECMO candidacy. That's all I have.
All right, can y'all see my presentation up on the screen?
Yes.
Yeah. Okay, great. I'm Josie Blakemore. I'm a nurse. I work as an ECMO specialist at Emory currently. We're going to be talking about kind of the environment of what it looks like going on ECMO. When the body's response to an insult or a pathology transitions from compensatory to maladaptive, or when it becomes overwhelmed, ECMO is a therapy that can potentially support the body's effort to respond and can be a potent therapy in resuscitation. So, in an effort to understand ECMO, and specifically the initiation of ECMO through this lens, we'll focus on these 2 questions. Reverse engineering the shock state and understanding what is that we're hoping to reverse with the initiation of EV ECMO. DO2 to VO2 ratio is a fundamental concept that can be basically understood in what percentage of the available oxygen in my arterial blood is extracted from the hemoglobin in order to carry out the metabolic processes necessary to sustain life. 5 component parts affect this ratio most significantly: hemoglobin, oxygen saturation, blood pressure, cardiac output, and consumption. Should any of these component parts decrease, then necessarily, in order to maintain an adequate oxygen delivery to consumption ratio, the other component parts must increase, with the exception of consumption, which would necessarily have to decrease as an adaptive response to an unfavorable ratio in which consumption begins to outpace our delivery. In response to respiratory failure, the compensatory response of the body uses several mechanisms: hyperdynamic hemodynamics, which includes high cardiac output, a shift from aerobic to anaerobic metabolism, in which the respiratory exchange ratio begins to shift to where more CO2 is produced than oxygen is consumed. This is due to a shift in lactate becoming the main source of energy to sustain metabolism, and CO2 is produced as bicarb buffers the increase in hydrogen ion production from the hypermetabolic state. In respiratory failure, this is also followed by an inability to expel the increase in CO2 through your native lung function due to the failure of the system. As the body's response shifts from compensatory to maladaptive, the process that the body is responding to, or the process that the body is responding to, is taking full effect, i.e., the distributive shock, vasodilation via endothelial nitric oxide production, a SIRS response, acidosis, compounded with the inability to deliver oxygen for these reasons. From a perfusion standpoint, it's only made worse in our respiratory failure due to an inability to get an adequate amount of oxygen into the blood through the native gas exchange. So the escalation of treatment in respiratory failure from a mechanical and pharmacological intervention standpoint include things such as positive pressure ventilation, intubation, high peak tables, sedation, paralytics, pulmonary vasodilators, proning, vasopressors, and inotropy. Once these therapies begin to fail by either not providing adequate gas exchange and delivery of oxygen, or the cost of providing adequate gas exchange and delivery of oxygen is extremely detrimental pressures on the ventilator, such as driving pressures greater than 15, or plateau pressures greater than 30, and or the use of high dose vasopressors. So where does ECMO come in and fit into this process, and how does it effectively deal with the shock state? In veno-venous ECMO, which is what we're talking about, blood is drained from the venous side, which is pre-heart, and sent through a membrane lung for gas exchange to occur, and then reinfused into the venous side, pre-heart. The ECMO pump now has the ability to address the DO2 to VO2 the critical VO2 to DO2 ratio that the patient is in. If you go back to our table of 5 things that affect DO2 to VO2 ratio, the ECMO pump can help address several of these factors by providing a high degree of oxygenation to the hemoglobin. Once we have an appropriate ratio of ECMO flow to native cardiac output, we can start to address the discrepancy between the amount of oxygen available due to the failing lungs and the amount of oxygen the cells of the body are requiring. The ECMO circuit also removes the CO2 and thus begins to reverse the deleterious effects of the respiratory or mixed acidosis resulting from the respiratory failure and ultimately the shock state. High cardiac output is often a characteristic of these patients and can be addressed by high flow rates on your ECMO circuit, decreased native cardiac output, both by correction of metabolic derangements and or by pharmacological interventions such as beta blockade. So cannula selection that will not only fit in your patient's vessels, but also provide an adequate amount of flow to be able to contend with their high demand is very important in providing adequate support. Initiating ECMO has several components we must take into consideration when initiating. Due to the body's response of being critically ill, as described earlier, the body can become hypercoagulable. This process only becomes exacerbated when the blood is exposed to the extracorporeal circuit. So we must be able to anticoagulate these patients in order to safely initiate ECMO and avoid rapidly clotting off the membrane lung, also known as the oxygenator, leading to failure of the ECMO circuit. Specifically in VV ECMO, a mostly normal heart function is required in order for this type of ECMO to be effective. Because of this, we have to be particularly aware of how the right ventricle has been affected by the increased pulmonary vascular resistance from the respiratory failure, and when rapid initiation of ECMO is required or resources for particular types of cannulas is not available, we have to consider, is the RV strain manageable or reversible with simply using inotropy and having a normalized pH and high amount of oxygenated blood coming from the ECMO circuit to decrease the resistance in the vascular beds of the pulmonary artery. Another consideration is the temperature of the fluid in the ECMO circuit at initiation. The heart is in a particularly agitated state due to all of the factors already covered, and a bolus of room temperature or colder saline to the coronaries via the ECMO circuit can stun both ventricles and or put the patient into deadly arrhythmias. As we correct the shock state, some things to consider is the pace at which we correct certain aspects of the internal acute environment that the body has been exposed to. Rapid decreases in CO2 has been correlated to worse neurological outcomes in this patient population by rapidly reducing CO2 levels and causing significant vasoconstriction in the vasculature of the brain. Another temptation is to rapidly reduce ventilator settings to a point that unintentionally de-recruits the patient's lungs and puts them at risk of ventilator-induced lung injury and all of the other risk factors associated with de-recruitment. Also, it's easy to underestimate the amount of gas exchange the native lungs are giving the patient once on ECMO. And rapid weaning of the ventilator can land you in a place where you have exceeded your ability to support the patient extracorporeally, and now you're in a position where you have to attempt to rapidly re-expand the lungs in order to support the patient. Additional considerations and possible complications that can result from cannulating for ECMO is large amounts of blood loss secondary to vessel damage and complications just from being anticoagulated and us pulling blood out of your body. This brings us to two important concepts in correcting the derangement caused by respiratory failure. Adequate hemoglobin for oxygen and CO2 carrying capacity, as well as effective circulating volume. The ECMO pump functions by the same mantra as all mechanical circulatory devices: preload dependent, afterload sensitive. In VV ECMO, we don't usually run into problems with afterload affecting the flow of the pump since we're in a low pressure venous system. Now that's assuming that our cannula is appropriately sized and in the right spot. But the pump requires volume to run, and that volume must be effective volume, meaning that it is largely able to carry gas, i.e. oxygen and CO2. Not only is an adequate amount of hemoglobin required to carry oxygen to the tissue and CO2 away, But this is important understanding the mechanism by which ECMO enables us to correct a critical DO2 to DO2 ratio by having an appropriately high content of arterial oxygen. Intravascular volume must not only be enough for the pump to function, but it must be comprised of an appropriate amount of hemoglobin to correct the imbalance of oxygen and carbon dioxide and CO2. So having blood available during cannulation is a good practice, simply in anticipation of complication that can arise that would hinder optimal care from being provided. Once the patient is on ECMO and beginning to stabilize, what one can expect in the days ahead is hopefully a progression through 3 phases: rest, recruitment, and recovery. The characteristics of these stages should all be looked at, ideally through being attained with lung protective ventilation strategies if they stay on the vent for the duration of their ECMO run. So characteristics of the rest period would be lung protective vent strategies this period is characterized with no to low tidal volumes, and also no to low gas exchange at the alveolar level. So this would be full ECMO support. As the patient's lungs start to recover while maintaining lung protective ventilator strategies, you'll begin to see low but improving tidal volumes. These tidal volumes are not going to be giving you a significant amount of gas exchange, but the value in this stage is the recruitment. And then hopefully recovery. Also under the umbrella of lung protective ventilator strategies, we should hope to see normal tidal volumes with being able to maintain the patient's metabolic needs with a normal minute ventilation, and it should be characterized by moderate to normal gas exchange. Thank you.
You guys are able to see the screen?
Yes.
Yeah, okay, great. All right, so we'll round this talk off talking about drug dosing considerations in ECMO. These are my objectives for my talk today, and I don't have any significant financial disclosures. Before discussing drug dosing in ECMO, I think it's important that we highlight some of the known changes that occur in drug distribution and concentration in critical illness alone. So in the table on the left, you can see the known changes that occur that lead to changes in drug disposition, with most of them leading to both increases and decreases in plasma concentration. Then when we add ECMO to the mix, we see an overall increase in volume of distribution due to drug sequestration and hemodilution, which overall leads to decreased plasma concentrations. Okay, so kind of diving into that a little bit further and looking at the factors that occur in ECMO that affect drug distribution. We see with the ECMO circuit, it has a very large surface area due to the oxygenator and mostly the tubing. Drugs that are lipophilic and highly protein bound will be sequestered into the circuit. This effect of drug sequestration over time is probably decreased due to saturation of binding sites. However, very little is known and very little research is done at this time looking at binding site saturation and reversible binding. So it's unclear how much that affects drug dosing over time. However, it's important to keep in mind in your patients who have been on ECMO for an extended period of time. In addition to that, our modern circuits have evolved, and so there is a lower risk of drug sequestration compared to the older models, but it's not fully eliminated, and it's an important consideration when you're looking at the literature and comparing older literature as compared to the newer literature, and kind of looking at the circuits and just being thoughtful of drug sequestration with different models of ECMO. And then the other factor that we see affected is hemodilution. So hemodilution generally occurs at the initiation of ECMO when we're priming the circuit and increasing our fluids and our fluid volume. So this mostly affects our hydrophilic drugs. Unfortunately, there aren't clear guidelines for drug dosing in ECMO, and a lot of that's due to the nature of our data, which is mostly lacking at this time. There is some ex vivo and in vivo data, but there's differences. So some of the things that we saw in preclinical trials didn't necessarily pan out in clinical trials. So right now at this time, the data is not very robust. And to highlight some of the challenges that we see with drug dosing in ECMO, I've included here the ASAP ECMO study, which was published in 2022. Which was designed to describe the pharmacokinetics of antimicrobials in ECMO. And it was really designed as like a real world study where the dosing of the various antimicrobials was determined by the treating team. And investigators took serial samples of drug concentrations collected over a single dosing interval. So dose was given and then serial samples collected to measure the different concentrations of the medications. They found a large variability in all PK parameters, and about 40% of samples did not achieve target concentration, with the majority of those samples being subtherapeutic. So even with our standard dosing, we're seeing that we're not oftentimes not achieving our target concentration, and mostly on the subtherapeutic end, which is concerning. Given the fact that we don't have a large amount of robust data at this time, and we don't have guidelines, we still have patients who are on ECMO who are receiving medications that need to be dosed for ECMO. So I wanted to kind of go over how I approach drug dosing in my ECMO patients. So the first thing I really think about is the therapeutic window. So the range between efficacy of the medication and toxicity, and kind of how big is that therapeutic window and what does the toxic effect look like? And then the onset of therapeutic effect expected. So something that is fast acting, such as vasopressors, sedatives, anticoagulants, I'm less concerned about if the medication is being sequestered in the circuit because we are titrating that medication to effect. I'm more worried about things that have a delayed onset, such as antimicrobials or anti-epileptics. And for the most part in my practice, I'm heavily focused on antimicrobials. So after that phase, then I do go to the literature to see what's available for the particular drug that I'm looking for. And even if there's not data out there that is prescriptive for how to exactly dose the medication, some of the literature can give some insight into whether or not I should be concerned about significant alterations in pharmacokinetics and significant decreases in therapeutic concentrations. And then after literature search, I go back to my PK principles to help guide my dosing regimen. So I look at the drug properties of the given medication. Is it highly protein bound? Is it lipophilic, which is generally indicated by a large volume of distribution? Or is it hydrophilic, which I'm a little bit more concerned about during the early phases of ECMO or during the initiation of that medication? And then I take into account other factors that can affect drug dosing. So renal replacement therapy we know has efficient drug removal, and there is some literature out there for certain medications that the combination of ECMO and CRRT can lead to significant decreases in plasma concentrations. Obesity can factor in. There's some guidance for obesity dosing for some of our antimicrobials. And then I consider the site of infection and, is it a challenging or difficult to treat site of infection that's difficult to penetrate? Is the indication for my antimicrobial, is it prophylaxis versus is it treatment dosing, which might alter how I approach dosing. So kind of wrapping up what my general dosing recommendations are. Again, I've been harping on there's no robust guidelines and the data is still in the early phases of development. So we really must rely on the principles of drug dosing to help formulate our drug dosing plan. So think about what is the therapeutic window of this medication, the expected therapeutic effect and the onset of that effect. A literature search can be helpful in guiding whether or not we should be considerate of significant drug PK alterations, and then consider the drug and patient-specific factors that might affect our dosing. And then my overall recommendations for drug dosing in ECMO is for most medications, especially antimicrobials, I always utilize a higher loading dose, and I utilize higher maintenance doses for our medications that are lipophilic and highly protein bound. For the beta-lactams, I try to utilize extended infusion strategy when appropriate, especially if we do have a known infection and site of infection that might be more challenging to treat. And then what is probably the most helpful is therapeutic drug monitoring, if that's available for the given medication that you're dosing. So with that, I will turn the presentation back over to Kyle, so I think we can answer some questions. You're on mute.
Thank you again. I appreciate that, and I also appreciate the presentation. But now I'm going to open up for questions, so please feel free to put anything that you guys may have in the chat. We do have a few minutes. I know I have one. This may, of course, go to the pharmacist in the panel, but I've heard some of my colleagues mention things like drug database and log Ps. Do you incorporate that into your management, or is that something that maybe not be best practice, if you will?
I think it's just a little bit more challenging to find that information because that does require more like specific data and research. It's not a typical finding that you'll find if you're looking up a drug in LexiComp. And I do also recognize that there's differences in ex vivo and in vivo data that we've seen with ECMO. So the accuracy of log P is probably done mostly in ex vivo settings, and so in where those preclinical settings where we haven't seen the correlation as well with drug or alterations in our pharmacokinetics. So I don't typically incorporate that in my practice.
Okay, thank you. Haven't seen anything yet, so I will use my time to ask one more question. As far as determining who to cannulate, I know we went over a few scores. How does the team, I guess, go through those assessments and collaborate to see who is an appropriate candidate, especially when they're miles and miles away and you have to coordinate that as well?
I think I can take that one. And so the process in which the consultation works is we'll get a call from the referring team stating, here's what's going on with the patient. This call is typically taken through our hotline by one of our ECMO coordinators, who currently are 3 critical care nurse practitioners. That call will then go to our CVICU attending, and as well as with backup, an ECMO administrator, which is myself and the other physician in our physician leadership group, to sort of discuss the case. If there is a bit of a question of, does the patient have, for example, pulmonary hypertension, we may call in one of our pulmonary hypertension specialists. Or the patient is potentially a lung transplant, we'll call one of our lung transplant pulmonologists. If there's a question about whether the patient would need emergent surgery from a certain specialty, we'll bring one of those specialists in as well. And then after that, it's a bit of a back and forth and discussion with the referring team as well as us. But in the lack of a unified electronic medical record system, most of it is communication through this discussion with the referring team. If at that time the patient's accepted for transport after that discussion, for cannulation after that discussion, we do have another check and balance, which is the cannulator. The cannulator then goes to bedside, and there have been times we've gone to either different units in the hospital or also different hospitals where we've gotten to bedside and say, you know, what we discussed maybe an hour, 2 hours, 3 hours, 6 hours ago is not the case anymore. Or, you know what, we asked these questions, but one of the things, right, we didn't ask was maybe this, and we're seeing this now at bedside. And this is actually not a good idea to cannulate this patient, or we'll sometimes get there and say, you know, what if we just try this therapy instead? And have been able to abate the patient from getting ECMO, and then instead have brought the patient back to our center for ECMO watch. And so there's a bunch of steps in that process where evaluates for candidacy, both pro and con for candidacy for ECMO, from multiple different perspectives and disciplines.
Awesome, thank you. We did get 2 more questions in the chat, so I will just close out with these 2 if that's okay with everyone as far as time. First question was, as far as medication administrations, do you give pre-oxygenator or post-oxygenator? Or does it matter?
We give them not in relation to the oxygenator, just like whatever systemic access that they have. So central line, if they have a peripheral line and it's appropriate for peripheral, it's not specifically in relation to pre or post.
Okay, thank you. And then the next question was with regard to a lipid medication. There was a question as far as insight on liposomal amphotericin B dosing. Is there a difference with the older versus the newer generation of circuits? And is there any concern with lipid medications when given with ECMO as far as like the circuit life?
Yeah, so I think that's a really good question because we actually have a few people who are on amphotericin and have been on ECMO for extended period of time. I think the concern is that there will be sequestration into the ECMO circuit, right? And I was actually discussing this with a colleague. There is some data we've used 7.5 mg per kg in some patients. The typical dosing is 3 to 5 mg per kg. And I was talking with a colleague, I think at ID week, they presented doses up to 10 mg per kg for amphotericin and ECMO. I think the question about the binding site saturation over time is one that we still don't have a good handle on. And amphotericin is not one that we necessarily do therapeutic drug monitoring with. And so at that point, I think it's really monitoring like what your toxicity profile looks like. And if we're starting to run into toxicities with higher doses, that might be a consideration for backing off, especially if you've been on it for an extended period of time.
Awesome. Thank you.
I think just to add to that second part of that question about changes in circuits, historically, particularly with certain therapies that are highly lipid bound, such as intralipid, these were contraindications for ECMO circuits. Thinking about though how ECMO circuits have changed over time, the initial ECMO circuit was the size of a piano, where it was truly a rotor that moved blood through. Then the next ECMO circuit that was used outside the operating room used an oxygenator that was about the size of a keg that you'd see at a college party, which then used some centrifugal forces, but was a large amount of transit time. Now we have oxygenators that fit in the palm of my hand, where the membranes and the flow of blood is very different, and there are very different types of oxygenators for that reason too. The circuitry's also become much more sophisticated, using less so mechanical centrifugal forces and using more magnetics and using more propelling forces from that standpoint, to where the amount of flow and velocity through the circuit keeps the circuit from clotting and increases longevity of the circuit too. So historically, certain medications and certain therapies were strict contraindications from just a clogging standpoint on ECMO circuits, which we're no longer seeing that to be the case.
Awesome. Okay, thank you so much. I do not see any more questions in the chat, so again, appreciate everyone for sticking with us, and I thank again our speakers for enlightening us and teaching us a little bit about ECMO saving the world. Thank you very much, everyone, and hopefully we see you again at the next bite-sized lecture.